switch things up here. Test 1, 2. Fantastic.
Hello there. So we are going to talk about direct laterals. Now, first of all, we talked yesterday about the OLLIF, transcameral OLLIF procedure, which is practically obliquely posterior. And I want you to again emphasize, in no minimally invasive surgery, it's about the skin incision, about the muscle sparing, about the damage that you don't do under the skin is what makes that minimally invasive, meaning that you don't disrupt the muscles, these muscles are multisegmental. The prone lateral that I'm going to talk to you as well use the double C-arm, and I will come back to that. And I think what's important is to understand prone laterals. First of all, let's talk about the laterals. They started late 90s and they really took off in 2000, but the numbers are actually going down. It's a very powerful procedure where you go laterally through the psoas, and you can put a cage with a large footprint, and it's and obviously the nature of nature of the laterals is that you avoid posterior element. That enables you literally to avoid all this muscle in the posterior and approach the spine through the lateral approach and bypass all the posterior element. Now, the number of the laterals actually going down in the United States. It's I would say at least it's an awkward positioning because patient is lateral, you have to stretch it, you have to, the rib cage and the hip, you have to separate them and so on. And as well, and then I did a handful of standalone laterals, and half of them failed. Then I backed them up with posterior instrumentation. That is a good procedure, but that's not one surgery, that's 2 surgeries. And it takes time to breaking the sterile field, repositioning the patient, doing posterior. And guess what? I did a posterior percutaneous, which is good, but then some people do prolateral, beautiful surgery, and then turn the patient and do a traditional open, practically they take the whole advantage of laterals away by doing the open posterior instrumentation. So, and doing prolateral has came in the last 10 years to be actually very fashionable, because you don't have to reposition the patient. Now, one of the problems with the lateral has been, as well has been that this repositioning takes, even in the best places, 40 minutes or so. You have to take everything off, reposition the patient, read the prep and drape, and so on and so forth. So people start doing this, putting screws actually in lateral position. And I met many of these surgeons who, they love the lateral, which works. But then they start putting screws, so not surprisingly, you can put the screws that go down easier than the screws that goes up. Meaning that, top to bottom, you put on the side, on the left side that's up, you put the screws in, but then on the side that it's very awkward to put it up. And the different anatomy actually was very challenging, let's say the least. With the navigation machines and so on, it got a revival, this kind of putting screws in the lateral position got a revival. But then few people, like Uribe and some other people, start thinking about, can we do really a direct lateral fusion in prone? Traditionally, patient is on the on the left side up. We go directly down, and all the anatomy was described that way. Now, and that is here. That's what we are talking about. Okay, so in a traditional procedure, in the direct procedure, patients laying on this side. You go through the psoas here, and this side is down, this side is up, And now when people start doing that, one of the advantages they don't get that all the abdominal cavity, abdominal organ, they don't fall down like when you position the patient in a lateral position. But more importantly as well, if you look at the field, it is very awkward position. If you haven't, you should actually go and watch one in person. It is a difficult setup, and it is, obviously we are surgeons. We get used to any difficult situation, and we can overcome it with enough education and training. Now, what I need you to understand, when you do this surgery, there is always, a regular prone lateral requires a very extensive, very complex retractor system. You remember the part that belly doesn't fall down like a regular lateral? You have to do a very extensive, the dissection and so on. And now, only this retractor system, there are two boxes, two sets, two sterile sets that contain only this sterile system. Now, after I did about 600 Olafs, I was thinking about I noticed in certain cases that I couldn't do the surgery before, like in L5S1. By the way, we know that lateral or prone lateral, they are never done for L5S1. And even in L4-5, because the lumbosacral plexus spreading out through the psoas, the rate of nerve damage is up to 35%. These papers that are published. Now, I started my Olaf procedure, and Olaf procedure can be challenging in L5S1. In the first year of doing Olaf, I noticed that every second 5S1 I have to convert to open surgery. But then after a year, I noticed I'm getting better. And just happened to be that I never just accept things. I was questioning, why am I getting better? Why I couldn't do it a year ago and now I could it now? And practically the eureka moment came from me looking back at my surgical pictures. And I will come back to that. I noticed in many of those cases that I'm able to do that, I am not in the typical Cambin triangle configuration. Let me explain it to you. Now, you're familiar with all the different approaches, and I want to emphasize Olaf is not a far lateral approach. Olaf is not a far lateral approach, it's an extraforaminal approach, posterior to psoas, and that hence we have the Olaf ATP anterior to psoas. These are distinct surgeries. And this is the oblique view. That is why you see the Olaf or Cambin triangle approach bigger than the DLF or direct lateral approach. In reality, the anterior to the nerve root, you have a huge space that when we do Olaf ATP, or when we do direct laterals, that's what we use. Literally, that's where psoas is, and we just punch through the psoas to get to do the surgery. And here again, we are visualizing in a true lateral. You remember, that was a oblique view. That's why DLF space looks smaller, but in reality, DLF space is much, much larger than, but that space is covered by psoas muscle. Now, when we do it in lateral position, the organ falls away. When we do it in a prone position, we have to be way more conscious about all the organs that are not falling away like in true lateral. Now, let's talk about the procedures here. Now, what I noticed when I look back at my pictures is that in many of those cases, on the X-ray, it seems that my tip of my probe is here and not here. I will show you on the X-rays what that looked like. And I think, in a way, my old boss, Dr. Nata, used to say, luck prefers the prepared. And that's why I was lucky to go back and evaluate my picture and notice that that is why I'm getting better in L5S1. So inadvertently, I have been anterior to the nerve root and going through the psoas, And that is not an olive procedure at all. That was a discovery of chance that I'm doing better, my patients are doing very well, and especially in 5S1, I have been doing prone laterals, where I wouldn't even dream to do it in a regular direct lateral. And this is how the picture looked like. This is obviously not L5S1, but in a regular OLEF, in the lateral view, you're just at the border of the bone, in the, as you see here, but in the MISD-LIF, you're truly anterior to the nerve root. But this is, I think, the important fact here. The important fact here is that I use the same instrumentation. None of this very complex retractor system that is required for the regular direct laterals. I use the same instrumentation that I use for the OLEF approach, but instead of being posterior to the nerve root, I'm just anterior to the nerve root. Same thing, I use a neuromonitoring probe. I go at 3 milliamp, I position it around here, then all the other steps are identical. This is what you need to do at direct lateral, prone lateral with this technique is no different than the OLEF that we discussed. But what you notice is that the cage is more horizontal. And then, as you see here, you see the difference. This is OLEF, this is direct lateral. And that became a rescue technique. I published that paper in 2017, and we have done over close to 370 of these cases. And it's the same instrumentation, same profile, same risk profile, a little different. I'm going to come back to that, but the risk profile, how it differs from an OLEF. As a matter of fact, I haven't published that data, but I do believe that the rate of neuritis is actually lower here. And then I'm asked, why don't you do it all the time? Why don't you, instead of OLEF, why don't you do this? Now, the disadvantage of this is you're poking holes through the psoas. And and contrary to you're all familiar with the risk profile of direct laterals, up to 35% nerve irritation rate. I mean, this is what the literature reports. So, and all those nerves, they are embedded in the psoas muscle here. And even though I'm using direct lateral, in this direct lateral, I'm using literally smaller cage. My cage profile is not as big as a regular direct lateral cage. Still, these nerves can get irritated. Another thing that we found out in doing this surgery is something that I haven't published a paper about that, but I have seen it enough to tell you that we call that iliopsoas compartment syndrome. Now, what I noticed that there are two kinds of nerve problem after this surgery. Number one is that you have neuritis. You pass next to the nerve root in the Cambic triangle, and the nerve root is irritated. Patient wakes up, they tell, I have numbness on top of my foot. The big toe is on, some patients say, big toe is on fire, okay? Doesn't happen, the neuropathic pain doesn't happen often enough, but often enough that it can be a concern. Now, I had a second group of patients. They wake up, everything is perfect. No neuritis, no L5. But then next day, they have problem to, the nurse calls you, the quadriceps is weak. You go and do examine the patient, it's not the quadriceps. It's not bringing the knee up, it's bringing the foot up, it's the iliopsoas. And that actually gets worse for a few days before it starts getting better. Once we actually got CAT scan, you see actually that even in the long run, some of these patients, the iliopsoas, they have, even sometimes in very few cases, atrophies. And that is for multi-level cases. You do multi-level cases, you poke through the iliopsoas like tens of times and so on. And what happens, it causes irritation, it causes sometimes hematoma, sometimes as well just swelling of the iliopsoas, which is in a very strong sheet, fibrous sheet, and it sort of suffocates itself to a certain degree. We learned to give some steroid to overcome that and so on. And so coming back to that, it has a very good risk profile, but it has not really become my go-to method because of this. So it's still OLLIF or transcaminolif is my go-to step, but in certain cases when the camin triangle is not approachable in 5S1, this is one of the alternative methods that enables me to still do the case, finish the case. Now, let's put it this way. You remember I told you in the first year I was doing that every second 5S1 I had to do the open old-fashioned way? The last time I planned to do an OLIF, but then I had to convert it, was 4 years ago, because now meanwhile we have 3 rescue technique, and that is one of the main technique that we use for that. But then, again, it enables you as well in some situation, like in some situation when I truly plan to put the cage completely on the other side, like I'm going always from the left, I want to put the cage completely on the right side to correct for sagittal deformity, for coronal deformity, I do this. In some cases that I absolutely want to put the cage in the front to correct for the sagittal deformity as well, the prone-lateral or MIS-DLIF, what we call, is a very, very good technique. So, but I'm just, what's important to me though is that this is exchangeable, meaning that you can do OLIF in many levels and direct lateral in some cases, and with the same instrumentation, you don't have to bring a new set to the operation theater and so on. All of that practically enables you to do the surgery safely. Now, I'm not sure if it's going to run it, but let me see if I can run you this video and then I stop. So, as you see, the surgery starts with measuring the parameter and the landmark on the skin. You go with a neuromonitoring probe, and I always try first to do an OLIF, and I go there, but here I wasn't able. Now you see the entry point is not up here, it's down here, it's anterior to the K-wire goes in, and then as you see here, actually what I'm doing right now, getting some, put a Jamshidi in the bone and getting some bone marrow probably to mix with my biologic. But then the next step after that is that while that biologic is soaking with the bone marrow, I enter the disc with the dilator and pay attention that when I enter it, see what happened here. You see some air gets sucked in, that's when the distraction or what we call anatomic decompression happens. Then the tube is an 8mm tube that goes in, the dilator comes out, and then the same tools, especially the discectomy tools are really what makes it possible to do discectomy, prepare the end plates, pack it with biologic, and then go there with the over-cannulated wire, go there with the cage. Now, I want you to go back and just look at that. The rest is the posterior instrumentation. It's not really doesn't really matter. But I want you to compare now this space. Look at this space there versus here. And if you measure it, you will see you have more than 3.5mm of distraction of the interdiscal space. And if you compare the foramen, which we did, if you add, in average person, if you add 2.5 to 3mm to the interdiscal and so interpedicular space, you're actually doubling the area of the lateral recess and the foramen. And for all practical purpose, this patient wake up and the leg pain is gone. I mean, it was hard for me to believe that. That's why I started getting a lot of patient testimonials. They came back and literally they wake up, they say, okay, I still have back pain, but the leg pain is gone. So it does work. This indirect decompression here, as in OLIF, really works. Okay, I'm happy to take a few questions if you have any.
Thank you.
Any question?
What is your experience about this patient in single canal stenosis and single ligament of the
So the question is if central canal stenosis and anatomic or indirect decompression? The answer to that is, now, number one, is the central canal stenosis osteogenic or is it soft tissue? That's why everybody get a CAT scan. Second question, when the patient sits down or lays down, does the pain go away? Now, if the patient lays down or sits down and pain does go away, that is a good indication that the configuration of the anatomy changes enough that literally, if you can keep that configuration when they stand up, then you can give them improvement of symptoms. Generally, I don't, let's put it this way, this is the statistic. I don't do this for every patient. I get a CAT scan on everybody. If there's a huge osteogenic or very calcified flavum, I do laminotomies. I don't do laminectomies anymore. I go and unroof the lamina. I still do those cases. But as of last week, I have done 1,818 cases of OLIF in about 13 patients. When I wasn't expecting to go back, I had to go back and do a direct decompression. So it's a less than 1% chance that even in your best, what you need to know though, I don't choose it for everybody, and in some patients, I choose to do OLIF and decompression at the same time. So, but in 30 patients that I thought indirect decompression is good enough, it wasn't. So it failed me in 13 cases.
So from that, one of the things that I always get asked, get asked in conferences talking about indirect decompression, which one is the best to use? A-lift, P-lift, T-lift, O-lift, X-lift.
Mm-hmm.
From what you just said there, in terms of the last 15 patients that you had where you had to change your practice, what if you were to say there's a protocol you have in terms of who you select for what is your protocol?
Yeah, the protocol is, now another person was asking, what does the patient want? Like some of my patients, my goal is to go to kitchen and make myself food, okay? And what prevents you of doing that? My back pain or my leg pain. Now, this is the holy grail of spine. What kind of surgery do we do for home? Now, but my whole ideology there is smallest possible surgery that gives the patient maximum clinical benefit. Now, if the leg pain is preventing you to go to kitchen, I do a laminotomy or foraminotomy. Or if you go to kitchen and you stand up for 10 minutes, but then your legs get heavy, claudication, I do maybe a endoscopic decompression and open up the space and so on. But if you go to kitchen, the reason you cannot make yourself food that as soon as you stand up, your back pain is killing you. Yeah, what about your legs? No, I have some legs pain, but the back. Now, is the back coming from 4 levels or coming from 2 levels? I do a myelogram and get the early and late myelogram, see how fast contrast is passing. In some cases, I know some people don't believe in discogram. In some cases,
discograms, we do that a lot.
Yeah, in some cases I do a discogram not as an indication to do the surgery, but to see if I can do instead of 4 levels, like if I can do 2 levels. Okay, so it's a very complex thing. But it comes back to that, direct decompression. We call it direct decompression because you cut the bone away, you cut the muscle away to be able to cut the bone away. You cut the bone away to give neural structure space. And that is absolutely required if the patient tells me that it doesn't matter. If I lay down, I have back pain, I have leg pain. If I stand up, I have leg pain. And then I see some it's really tissue that I cannot approach it with this kind of procedures, okay? Now, having said that, for the first few years of my practice when I started doing the OLIF, I was over-distracting. Because I didn't understand that, I didn't believe in indirect decompression. We published our paper about physiologic decompression about 5 years ago, where it shows you do not have to go, like when I was TLF, My cage sizes were between 7 and 10. 10 was the highest cage I would put in a TLIF. I mean, what kind of cages do you guys put in when you do TLIF?
All 5 millimeters.
Yeah, usually, 10 millimeter was quite large, and 11. Now, when I went to this, I just wasn't really believing in direct decompression or enough. So I was over distracting it. I had a high rate of subsedation.
The patient wakes up with real bad back pain afterwards when that's the problem.
Yeah, but what I noticed is that I don't need to over distract them. Like 11, 10, 11, 12 is really good enough to give them clinical improvement, but reducing the risk of subsedation and pain, back pain coming back, cutting it in 1/4, in 1/5. Okay? Okay, thank you very much.
What is the exact parameters you use to say how much of the foramen gets enlarged with how much of this restoration?
So we looked at like 40 cases. We measured in the CAT scan literally the interdiscal and interpedicular spaces. They correlate 1-to-1. Meaning that certain especially that if you increase the interdiscal space 2 millimeter, interpedicular space almost invariably increase to almost the same amount. So it's a linear correlation between interdiscal and interpedicular space increasing. Then we looked at literally simple math. We measured what that increase in the distance was, and then we, on a CAT scan, you have that tools in any PAC system has, we looked at the area. Because how you calculate the area, which is the R2, meaning the exponents of the radius, by increasing that distance in 2.5 to 3 millimeter, you're not adding a little, you're doubling the area of the lateral recess and foramen. And we correlated with the clinical improvement practically, and we found actually later additional papers that if you increase that, that paper was 4 millimeter, that if you increase the foraminal, interpedicular space 4 millimeter, for all practical purpose, most of clinical radiculopathy symptoms go away, and radiographically, it makes a huge improvement on the parameter of what radiologists call as a stenosis. So it was a correlation between actually 40 cases that we measured interdiscal, interpedicular space, linear correlation. We literally use one of the tools of the PAC system to measure the area before and after, which shows in average patient, like most of our patients are obviously irregular Caucasian. I'm sure in some other countries, like in India and so on, some other parameter may apply. That 2.5 to 3 millimeter increase in interdiscal space doubles the area of the lateral recess and foramen.
Thank you.
Okay, thank you.